Hi, everybody. Danielle Hicks here with GoTo Foundation. I hope this is working. Welcome to the new sort of modified version of the Lung Cancer Living Room. We're happy to have you all here, wherever you're watching from. Please give a shout out, as we've got moderators as usual on our Facebook Live and our YouTube stream accounts. So please feel free to give a shout out and let us know where you're calling in from. I just want to let you guys know who are, those of you who are used to watching the Lung Cancer Living Room the third Tuesday of every month, that during the time of coronavirus, we have decided to create a rapid response living room. So we will be modifying it in that way throughout this time. And we will be coming to you live every Tuesday at 1 p.m. Pacific for 1 hour. We're trying to learn, how to live and work within the confines of the coronavirus, because it really does feel like we're confined in this space, whether personally or professionally. And we're trying to really be able to develop a way to communicate with you what's happening right now, not only with the virus, but what's going on with lung cancer. So we've got some plans, that we're going to consider, given that this is a fluid environment, nothing is set in stone. We want to follow along with the new information that's coming out on a daily, if not hourly basis. But some of the things we're planning on bringing to you in the weeks to come are conversations around telehealth, how and where to access it, how science and research are adapting in this new sort of space that we're all trying to figure out how to navigate. Also, we're going to be talking to some nurse navigators, some conversations around coping and some psychosocial support that folks might need, and other things to come. But today, as you guys can see up on the screen with me, I have Amy Moore, who most of you know, PhD, Director of Science and Research at GoTo Foundation. I have Elridge Proctor, MPA, and she's the Senior Director of Government Affairs at GoTo. And we have Upal Basu Roy, who is a PhD, MPH, and the Vice President of Research at LUNGevity. And then last, but most definitely not least, Janet Freeman-Daily, who is a survivor, advocate, and co-founder of the Ross Wonders. So we're thrilled to have everyone on board today to bring to you a conversation really around a couple of different things. One, we want to talk about the collaborative effort that these folks and others have pulled together in order to bring and deliver to you relevant information as it pertains to COVID-19 and how it's impacting the lives of patients everywhere. This is an effort by GoTo, LUNGevity, Lung Cancer Research Foundation, Lung Cancer Foundation of America, and LungCan. Everybody's kind of coming together and agreeing to work on this project and deliver the same message. So I want to kind of point out and start to the team up here, or ask the question, why is it we've decided to come together for this messaging, and what is it we're hoping to get across to everyone? So I'd like everybody to kind of comment on it. Amy, if you want to start, and then we'll go to Upal and Janet.
Well, you may not realize this in looking at Upal, Janet, and myself, but we're actually triplets. Janet's the smartest of the three of us. She figured out how to bend the space-time continuum, and we were actually born on different continents in different decades, but all joking aside, it's a joy to work with these people, and we text back and forth multiple times a day, every day, and we're laughing and crying through this. I think we're helping keep each other sane, and the reality is we share an intellectual worldview, but I think beyond that we share a heart view, and we recognize that it's in this unprecedented crisis, we're all better together, and we all bring something unique to the table. Me being a virologist, Upal being a master of public health, and Janet being, the scientist that she is, but also the survivor and patient advocate that she is. And I couldn't be more thrilled that, they share that viewpoint of we do what's right for the community we serve and the people we serve. And, this team is incredible, and I'm just so honored to work with them.
Oh, I would second that, or third it, if Upal wants to go second.
In fact, I've third, fourth, and second, and seventh, and ninth. It's just, first of all, Thank you so much for having me on this living room. It's a privilege to share the floor with my fellow panelists. And as Amy mentioned, that Janet, Amy, and I have been working together for the past, I would say, almost more than a month. In fact, it seems like a blur right now since COVID-19 hit us. And I think this is, COVID-19 has sort of really taught us that we as an advocacy community need to come together. Our patients need to hear a unified voice. And I think another very important piece of this collaborative effort is also to make sure that our patients are getting up-to-date and accurate information. I think there is a lot of misinformation floating around during the time of COVID-19, and I think it's our responsibility as the advocacy community to make sure that we provide the right and correct information to our patient. And I think that is the power of this collaboration.
Yeah, I was so thrilled getting to know Upal and Amy over time, and we actually got to spend quite a bit of time together at a meeting in January, and I learned more about their backgrounds. And then when this COVID-19 hit, it's like that they have just the kind of backgrounds that we need for this. And I knew the patient community was really hungry for information. So we've been doing our best to gobble up everything we can and put it in a form that makes sense. I've had a wonderful time working with them. And it's really nice to be able to bounce ideas off of them and share frustrations and come up with approaches to solve things. It's been a terrific collaboration. I hope it continues long past the time COVID's over.
I think that's the reality, Danielle, is that we're all, clamoring for information and drinking from a fire hose and, trying to discern what's fact, what's fiction. And, we have an obligation to our community to sort through that, to source the best, timeliest information. And so we're trying to be very intentional and coordinate between ourselves to divide and conquer, so just the three of us, we have a Google sheet where we're keeping track of, these are the webinars and seminars that I'm, participating in, and we're taking notes and sharing between ourselves so that we can cover as much ground as possible and provide our community with the information that it's hungry for. And, it takes all of us working together, and, now is critically important that, we lay aside, ego, and none of these people have ego here. They just have a deep concern for the community that we all care about. And so that's what unites us, and that's why we're here.
I especially appreciate that one of us will come up with an idea and the other ones will start building on that. If somebody drafts something, it's not about these are my words and it's got to be my way. It's what makes the most sense. We've all been willing to modify and share information so that we get things out as quickly as we can in a way that sounds right.
I love what all of you were saying. I think that the unity is such an important thing across the board during, the COVID-19 crisis, but even outside of that. And if there is a silver lining to be found in any of this, I think this is one of them, is the collaborative efforts and the unification of a voice for our community. I think it's fantastic. I'm going to step back for 1 second. So for those of you watching who don't know, the updates come out weekly and they come out on a Monday. So, once these came out yesterday, they've immediately been starting on, and noodling, around in their heads, what is the most important thing that we need to message out to you guys next Monday. And one of the reasons that we decided to have the rapid response living rooms on Tuesdays was in order to be able to verbally deliver to you the messages that are pushed out in writing. And before we talk about what just came out yesterday, can you guys talk a little bit about what has been reported on in this collaborative effort so far?
Upal, would you like to start, and then Janet and I can add to?
I think, first of all, I do need to point out that the COVID-19 and SARS-CoV-2, they are two very fickle things. And unfortunately, what we knew a month ago, that has already changed. And I think there is new information coming out every day. And I think our doctors are learning, we as advocates are learning, and our patients are learning. And I think all our updates thus far have focused on the most relevant topics for our community. And I'll give you an example of a couple. For example, treatment in the time of COVID, then accessing clinical trials during the time of COVID. So all the updates that we do it sort of very selectively, thoughtfully, and taking into account what's the most accurate information that's available at the point of doing the update. And that's actually one of the reasons we selected Monday, because we wait till the weekend to gather all the information that's come out during that week. And then Amy, Janet, Christina from Lung Cancer Research Foundation and I, we are furiously working on a Sunday evening to make sure that first we distill that information out correctly, and then make sure that it's digestible for our patient community. And that's sort of been our approach.
But I think, going back, we started this March 3rd, I believe, was our first update ever. So we're a month into this. And, it started out with basically just trying to explain what is SARS-CoV-2, what is COVID, and going through then, the things that we know we can do, right? We don't have existing treatments. We don't have a vaccine. So the only tool at our disposal is social distancing. So we've talked about that. As Upal said, we talked about, the current impacts on existing cancer treatment and clinical trials. And then, of course, we kind of have a mechanism that we've put in place now to source our ideas and content for the coming week. And so we're trying to schedule this out weeks in advance at this point. And, in all fairness, Upal is correct. This is something that is unfolding in real time, and our knowledge is changing in real time. We're learning as we go. So, some of the things that we're learning, may change and may even negate some things that we thought a month ago. And that's just the reality of how quickly all this is changing. But, we are trying to provide, the references, the citations, so that people can go out there and cross-check. And as we've said through all this, we want people to go to reputable resources, so going to the World Health Organization, going to the Centers for Disease Control and Prevention. There's so much out there in the age of the internet and social media, and I think as scientists, we feel an even deeper sense of obligation and responsibility, me being from the South in particular, just seeing, the fear and the concerns and the questions and the rumors that are out there. And we're trying to be a voice of reason and accuracy to the best of our ability, knowing that that may change over time. But yeah, I have confidence in the integrity of the people that are on this team, in making sure that we get it right, because that matters, for all of us.
Thanks.
It was also an interesting coincidence that we represent the three hardest hit areas initially. I'm from Seattle, Amy's from California, Upal's in New York City. And so we were getting stuff locally and talking to each other before it was coming up in the rest of the nation. And we also have different information networks connected to different hospitals and doctors and such, so we can start cross-referencing things and when we see presentations that the doctors are in, we can check with each other and say, hey, did you hear that somewhere else? And so it really is bringing together a very wide net of resources.
I think it's wonderful. It's so important. Sorry, Upal, go ahead.
I was just going to add, Danielle, going back to what Amy was talking about, for those of you who are listening in and who've not had a chance to look at the updates, we highly recommend that you actually start looking at the updates right from the beginning. It'll actually give you a very good perspective on how the disease has evolved and how knowledge about lung cancer in relationship to the disease has evolved.
Absolutely, absolutely. So with that, I want to kind of segue into what this week's updates were. But to your point, Upal, anybody who has not been keeping up with the updates or didn't know that they were there, please, please, please go to our website, LUNGevity's website. All of the partners are rolling out this information. So you can go to any of those places and go back, and you'll see sort of the evolution to date from when we started this. With that being said, and Amy, you touched on it a little bit, or at least I heard the words that are starting to become like, you know, foul language in some households right now, but you mentioned social distancing. We've all been social distancing for some amount of time, at least. Well, I shouldn't say all. There's still some parts of this country and others that aren't practicing yet. But talk a little bit about social distancing and whether or not it's working.
Yeah, I mean, I think, you know, as we brainstormed last week about what we wanted to focus on for this week's update, you know, it was my sense that we're all getting a little tired now. You know, we've had a little too much family time. We're getting sick of the people we love, even though we love them a lot, you know, getting tired of being cooped up.
Counting over here.
Right. And so, you know, I really wanted us to have an epidemiology kind of heavy update, if you will. And that was to reinforce the message that social distancing is working. You know, to Janet's point a moment ago, she being in King County, Washington, which was the initial epicenter of the pandemic here in the US, and me being in the San Francisco Bay Area, Upal being in New York City, we've been on, you know, the front sides of this, the front edge of it, and really seeing the impact on the West Coast of early stringent policies that were put in place. And because of that, we're beginning to see hints that we're flattening the curve. That's the other, you know, key language that we're all, you know, incorporating into our everyday language now. We know that it's working, and it's critically imperative that we don't let up just because it's starting to get uncomfortable and starting to get tiresome and people are bored. You know, this is something we have to maintain. And so much so that even in California, where I am, we extended that, you know, shelter in place policy through early May. We made it more restrictive because we see that it's working, and we know that doing more is going to save more lives. So yes, social distancing is working. And, you know, so that's encouraging because, as I said, this is a virus for which we don't have an existing treatment. We don't have an existing vaccine. None of us are immune. The only steps we can take to protect ourselves are these: social distancing, washing our hands. Upal's the public health expert among us. You know, he can speak very eloquently on why all this is important, but we know it's working. So yes, we have to keep doing it.
Yeah, and I want to go to Upal next around.
Can I jump in on one thing first?
Sure.
So just to say, in Seattle, we started social distancing before anybody else. And the reason we did is we have the great advantage of having the Fred Hutchinson Cancer Research Center here in Seattle. And they happened to have a flu study that was looking at the spread of flu in the population and happened to test some people for COVID as part of that, and discovered it was spreading in the community. And within days, our governor listened to Fred Hutch and they started shutting down. We had people who knew what to look for, and the scientists who could make a case, and politicians who listened to them. And that's one reason that our cases are not climbing as fast as anybody else.
Yeah, I think that's a really good point, Janet. And I think that the similar type situation has happened here in California. And Amy kind of touched on it. You know, some of the restrictions have gotten even sort of tighter, in that if you can't ride your bike outside of a 5-mile radius of your home, you know, so they're really kind of making sure that people are staying where they live. So really, really great point. Upal, can you talk a little bit about why it's important to social distance and what social distancing really means? Because I still don't necessarily think I'm seeing people practice proper social distancing. And I also, just on the flip side, see it somewhat turning some other things into potential dangers, i.e. people are out riding their bikes and they are trying to social distance, and I'm driving my car to the grocery store and they'll jut out in the middle of the road in front of me so as to not get too close to somebody else riding their bike or walking. So can you just talk about proper social distancing and why it's important that we continue to do it?
Absolutely. So social distancing, very simply put, is just avoiding crowds. That's basically social distancing. You stay away from crowds, and the crowds could be public gatherings, They could be going to the grocery store where there are lots of people. They could be actually going to the park and playing with your kids. All of these public gatherings or crowds, staying away from them is social distancing. And the CDC actually has sort of numbers associated with social distancing. So when you maintain a distance of about 6 feet or 2 meters from the next person, that's actually adequate social distancing. And yes, I do understand, as Amy mentioned, I think we are all going a little crazy staying inside. And especially with spring around the corner, I think we all want to leave our apartments, we all want to leave our homes and enjoy the beautiful weather. But social distancing is working. It's the only public health measure as we have right now. As Amy mentioned, we don't have a vaccine, we don't have a treatment, and this is a new virus, so we do not have any pre-existing immunity. So social distancing is the only public health measure we have right now, which is on our side. But I do also want to make a point about social distancing and social isolation. I think people sort of mix the two. Social isolation is not the same as social distancing. In fact, this is the time when you should not be socially isolated. We have at our disposal a lot of remote technology. We have cell phones, we have video calling apps. So please make sure that you reach out to your loved ones, to your family, to your friend, and keep in touch with them. As I said, social distancing is not the same as social isolation. So please do not social isolate.
So I have a sort of a tag-on question to that. If we discontinue social distancing too soon, what are the possible ramifications of that?
Flare-ups.
So, Amy, actually, do you want to take a stab? Go ahead.
No, you go first.
So Danielle, the way a virus sort of infects other people, so we actually can measure the infectivity of a virus. And to give you some context, an individual who has the flu infection infects one person. So that gives you an understanding of how infective flu is. But in the case of COVID-19, one infected individual can infect 2.5 individuals. So it's much more infectious than the flu virus. And another thing to keep in mind is that a lot of people who have been infected with the COVID-19 virus, they may not show symptoms, but they are still infectious. And that's why if we stop social distancing, we do not know who we are getting exposed to. And that's just basically making sure that the virus continues to stay on in our community.
So could it potentially be all of the sheltering in place that everyone's been doing? Janet, I think you said 6 weeks now. We've been a little over 3 weeks, 4 weeks now. I can't remember what day it is half the time. Are we effectively sort of, or essentially, by not continuing to follow these guidelines, are we kind of going back to day one? Or like in this space? I mean, is it going to take longer to come out of if we don't continue to do it?
Well, there's a couple of things we can point to here. You know, we've all probably gotten used to looking at these exponential curves now, and especially there's a great graphic in one of our previous updates, you know, showing about flattening the curve and how we can push that out and keep the healthcare system from getting saturated. But when we go about social distancing in this kind of piecemeal fashion, where, as you said, there are some states that aren't yet practicing social distancing as stringently or at all as other places, we're just kind of lengthening the process for all of us, right? The process for which it takes the virus to kind of go away or calm down to the point that we can manage it. But we can also look at places that, you know, had the virus under control and began to loosen restrictions, like Hong Kong. And when they did that maybe too soon, we start to see these flare-ups again. And I think that is a concern that we all have, is that, you know, the expectation is that this virus may become part of kind of our seasonal landscape, you know, flu, COVID, you know, common cold. And so we're going to have these flare-ups around the country. You know, we saw it early on the West Coast. You know, New York is in the midst of it, but maybe starting to kind of hit their apex. But there are parts of our country that have not yet seen the full burden of COVID yet. And so the tsunami is still kind of coming for them. And so that's why the sooner we can kind of have a broad sweeping shelter in place policy, the better off we'll all be, and the sooner we can get under control. As we continue to do this piecemeal fashion, that just makes it longer and more difficult to contain.
And I think it's also important to point out that social distancing is not saying that we're going to let the virus run its course, and when we come out of the house, nobody's going to get it. What we're trying to do is minimize the number of people who are getting it all at one time so that we don't overwhelm the healthcare system. We expect that once we come out of sort of isolating ourselves at home, that we're still going to see cases, but hopefully we just won't see as many all at once.
I think another thing that we hope for, from a virology perspective, we talked about vaccines in the past, and this concept of herd immunity, and will we or will we not have herd immunity in the population? Will enough people have been infected to protect those who have not yet been infected? And we don't know the answer to that question yet. So I would expect realistically what we can, foresee is that we might have these periods of, sheltering in place, and then we might begin to be able to loosen some of those restrictions in places that have passed their peak. Washington, California, we're beginning to see maybe some light at the end of the tunnel, but as we emerge, it's possible that we could see these pockets of flare-ups, and we may have to go through an extended period of extension, contraction, where we, kind of relax those measures. And then we kind of have to come back in for a little bit until we can get to the point of having a vaccine or an effective therapeutic. So, realistically, that's what we're looking at.
Okay. So, and I don't want to belabor this too much because I want to get on to the next question, but so let's assume for a second, hypothetically, California, we'll just keep that as an example. We start to sort of loosen the strings around what this social distancing looks like. But then we have people getting on planes, flying to other parts of the country who may not be in the same situation, and then they're coming back home, right? I mean, I guess I'm just trying to wrap my head around, and I've heard some scuttlebutt out in our community around, does everybody have to do it at the same time in order for this to be effective because of things like that? Because people are traveling outside of their states, outside of their countries. Do we know?
I don't know that we fully know. I've seen different discussions of plans for how we begin to restart society, if you will, how we restart the economy. And I think a lot of people are being very thoughtful about what that looks like. And it won't be just a flip of the switch and we're back to normal as we once knew it. I think it's going to be a gradual process. And, I've seen some discussions of how that might look in California. And, as we get to thinking about that path forward, it may mean that for a period of time, we're still not going to see large gatherings. We're not going to be having big sporting events or places where we come together in crowds like at the theater. It may mean restaurants can reopen, but they'll have limited seating, and we'll still try to enforce some level of social distancing as a precautionary measure. And I think until we get to the point where we have wide rollout of testing, until we have wide rollout of serological testing, that's where we can test you for antibodies to determine if you have been infected and may have, some form of immunity. We just don't really know what that's going to look like. In other countries, in Europe, there's been discussion of issuing certificates of immunity. So that would allow you to re-enter, the world, if you will. There was some promising data and work coming out of Stanford where they're developing an antibody test that may soon be rolled out to Californians to, test whether or not we've been exposed. So there is not an easy answer because there's not a 100% uniform policy across the country. But I think that is a concern. If we kind of just immediately you know, I get on a plane and I go back home to South Carolina to visit my family because, you know, I miss them and I'm concerned about how they're doing. And then I come back here. Am I picking up something and seeding a new outbreak here? It's within the realm of possibility. So I think that's why we have to be thoughtful and smart about how we reopen society, if you will.
So that's a good sort of segue into Janet. The question around, do I leave my home to go someplace safe, i.e. my cabin in the woods or, you know, my vacation home somewhere else? This is kind of what we're talking about. And it's the same, even if it's in the same state, is that something I should be doing?
Short answer is no. It's just as Amy and Upal have said, we don't know who's contagious. We don't know who's got the virus. We don't know who can spread it to other people. So if you pick up and go to a rural community, you have the potential to expose all of them. And rural communities don't have the healthcare facilities that big cities do. Some of them might not even have one ICU bed to serve an entire county. If you bring that disease in, you are putting all those people at risk of getting the disease and not having the option for getting treated. And that's just not thinking about the community as a whole. Yes, it's nice to think about retreating to your nice, safe little vacation cabin and not have to see other people and be in a pretty place. But you have to think about the risks of the people who live there full time. They may not have a grocery that's stocked often enough to support more people. And certainly most of them do not have internet that would support you working at home and streaming your television. So, you know, think about the other people involved. This isn't just how to keep your family safe. We're trying to keep the whole community safe. And they're trying different ways of dealing with it. Here in Seattle, we have quite a homeless population, and they're actually placing some of the people from homeless shelters into hotels just to be able to keep them separate.
So I've got it before we jump into, thank you, Janet, before we jump into, and I know before I jump into what I'm going to jump into, I know people are getting stressed out. I know I'm getting stressed out, right? Some days are easier than others. Some parts of the day are easier than others, right? Being home. I've got 3 grown children now living at home with me for the last month. And they eat a lot. They use a lot of toilet paper. They're constantly behind me when I'm trying to have meetings and Zooms. My dogs are barking. It's hard and it's stressful. So I get that and I appreciate it. But I really hope that, you know, based on some of the, albeit short conversation we've had thus far around social distancing and why it's important, that people are really picking up that message. It's about keeping yourself healthy and keeping others healthy. So
and I just want to reiterate, it's also about giving our healthcare workers and our scientists that leg up that they desperately, desperately need. We have to protect our front line. The hard reality is we are losing a lot of our healthcare workers and risk losing many more. And so they deserve every chance that they can get for us to do our part. We're not asking people to do something, you know, that's that hard. You just have to stay home. And by doing that, you help them be able to have the resources they need to treat people. And we don't want to overtax or overburden the healthcare system. You know, we've seen how that has played out in other countries around the world. And the researchers need the time that they need to develop, you know, effective treatments and the vaccines. And so to the extent that we can put in place these measures, which are the only tools we have at our disposal right now, we need to use them.
I love the one meme that I saw on Facebook. It said, we have one job, to stay home and lay on the sofa in front of the television. Let's not screw it up.
Right? I know. We've got some questions coming in from online. One sort of relates directly back to something we were just talking about, and then I'll get to the others as we're kind of going along. But what does it mean for high risk folks getting back into the new world, as they actually are calling it in the question? Is it going to be different for them? Do we know if it's different for them? Is it going to be the same for everyone? Any thoughts on that?
Well,
You want to go first, or Janet?
just a quick, until we have a vaccine, for a way to test whether or not is immune, we really have no idea what this world is going to look like. Feel free to disagree.
No, I think you're spot on. I think the reality is that, you know, if you are what we would consider high risk, then you need to maintain those practices for, you know, as long as it takes for us to get an effective treatment or an effective vaccine. And that's hard to kind of comprehend and wrap your mind around right now, because that seems too long. You know, it just doesn't compute. You know, we don't want to think in those terms, but I think that's the reality we need to be prepared for. Upal, as a public health person, you probably have some thoughts as well.
I think the only thing I would add to what Janet and Amy mentioned is I think this definition of high risk. I think initially when COVID-19 was detected, there was a lot of discussion about patients with only comorbidities such as lung cancer, such as heart disease, such as diabetes being at high risk. But that actually has changed. In fact, a lot of recent data from the CDC clearly demonstrates that pretty much the entire population is at high risk of catching COVID, at high risk of developing complications from COVID, and at high risk of ending up in the ER. So I think we need to be careful as a community. I think COVID-19 is it's a community pandemic, and I think we cannot think of individual level solutions. We have to think of community level solutions here.
Yeah,
Great.
Right.
That's a great point. There was another question online about, well, one I think we can touch on really quickly. If they discover a vaccine, how long until it would come available realistically to the public, and would it still have to go through the same sort of clinical trial approach?
The short answer is yes, it still has to go through all of those same, you know, trials and process to ensure safety and efficacy and all that. And so, you know, most of you have probably heard Dr. Anthony Fauci talk about, you know, realistically, we're talking maybe 18 months, and that is extraordinarily fast in the world of vaccine development, where it can often take up to a decade to deliver a new vaccine. So that, I think, is best case scenario if everything goes perfectly. But the good news is there are at least 40, maybe more now, vaccine efforts underway. Maybe you've heard of one being developed, an mRNA vaccine being developed by a company called Moderna. And, you know, in parallel with that, there are also companies pursuing antivirals, and we're looking at repurposing existing drugs. So a company called Gilead had developed a drug called remdesivir, which, you know, for the viewing public would be equivalent to Tamiflu if you get infected with flu. So it's an antiviral that, you know, can kind of hopefully have some effect once you become infected. So there are lots of scientific efforts underway. There are resources being deployed on this, but you're right, it takes time. They still have to go through trials. There are mechanisms to fast track, you know, these efforts, and those mechanisms will be put in place. But then we have to think about, how do you ramp up and manufacture this at scale for a global population, you know? So it's a Herculean effort to do this. And so that's why we need to make sure we do our part. You know, we've got the easy job. We just have to sit on our butts at home and let the scientists do their thing, and, you know, give them the time that they need to hopefully figure it out.
I wanted to add a couple things to that. There's a couple other studies that are going. They now have a preliminary serum test to determine if you have immunity, but it's available in like 1 or 2 research hospitals, and they don't have the capacity to get it out to a lot of people. So now they need other hospitals to set up the equipment to be able to do those tests and get approved to do it. And they have to have enough of the chemicals to do the test. So there's a ramp up issue. And they just this week started giving people who have COVID-19 the serum for people who have known to had it and have recovered. They call that, oh, now I'm going blank.
Convalescent serum?
convalescent serum, thank you. And the problem with that here is that there's a lot of people who probably had it, but nobody could get tested. So now they have to figure out how to determine, they need the test to find out if we've got the antibody so that they can give the convalescent serum to other people. So there's part of it is just trying to get all of the chain of events put together so that things can happen.
But I think that's the encouraging thing, is that just just as we as lung cancer advocacy groups have come together, the scientific community is coming together in unprecedented ways, and data sharing and reagent sharing, knowledge sharing. My husband is one of the ones, he has a company to work on vaccines, and just the conversations he's having with people. I mean, it's mind-boggling in a good way, the speed with which we are understanding this virus. So you have to remember, this is a novel virus that emerged in December of 2019. We didn't even realize it existed until the end of December. And here we are, with vaccines that are already in clinical trials, with therapeutics that are already in clinical trials. I mean, that pace is breathtaking, and that's a good thing. And so, as scary as all this is for everybody, being a scientist, I have an extraordinary level of hope, because I see what has been accomplished in just a few months, which is, if this had happened in, a decade earlier, we probably wouldn't be in the position we are now, because our ability to sequence and understand just the technologies we have even now didn't exist, just a few short years ago. So that's encouraging. That's in our favor. And so I am hopeful because of those things.
Thank you for that, Amy. I want to jump to this next question before I move over to Elridge to talk about some challenges and some very real fears that our community is facing right now. But I want to kind of close the loop on this social distancing conversation and ask you, Upal, from a public health perspective. Early on, there was a lot of conversation about obviously healthcare providers and those who were symptomatic wearing protective masks. Now the recommendations are coming out that everyone should be practicing this sort of mask wearing, be it a homemade mask, or it doesn't necessarily need to be N95. Can you talk a little bit about that and why or why not that's important?
I think a couple of weeks ago, there was no evidence that the virus was actually being transmitted by air, because there was a lot of research going on. But emerging evidence suggests that the virus can actually spread in between two people when they are talking, because it can be carried by the aerosol that typically a person sort of exudes when they are talking. That's a normal process. When I'm talking right now, I am actually exuding aerosols, which is basically invisible to the naked eye, but it's still there. And there is evidence that suggests that the virus can be transmitted through aerosols. And I think the CDC has been very, very proactive in telling us now that we need to be wearing masks for this reason. Again, a homemade mask is good enough. And in fact, I would recommend that go to the CDC website. They actually have a do-it-yourself mask making video, which is excellent, and make a homemade mask, especially if you have to go to the grocery store or if you have to leave your apartments. And I would say that especially for caregivers to lung cancer patients who have to go out to sometimes replenish supplies, groceries for their loved ones, I think it's incredibly important that if you're leaving your apartments or your homes, that you use a face mask of some shape or form, and a homemade mask is absolutely fine. And Danielle, in terms of your second question about traveling, I think my very, very dogmatic public health answer is, please don't travel. I don't think anything that is non-essential, and in my opinion, most travel is non-essential. If you can avoid traveling, please avoid traveling. And I use New York City as an example. If I, who lives in a COVID hot zone, if I decided to travel to Wyoming right now, it would be highly irresponsible of me, because even though I may be asymptomatic, I may be carrying the virus with me to Wyoming. And the reverse is also true. Someone from Wyoming, if they were considering traveling to New York for work, I would completely recommend against doing it, because again, yes, Wyoming is safe, but you don't know what you're going to bring back from New York City. And I think the third piece of travel, which I think is incredibly important to the lung cancer community, is for caregivers. And I'm very, very respectful of the fact that caregivers of jobs that may require them to travel to other cities. But I would recommend that as much as possible, minimize non-essential travel.
That's great. Thank you, Upal. A question came in while you were talking about the masks, and it says, in your opinion, would full face shields be more effective for self-protection going out into the stores because it covers your eyes as well?
Amy, do you want to take that, or I can?
You can, go ahead.
I think there is some evidence that has come out that shows that the virus can actually infect the conjunctiva, which is basically the layer in the eye. So there is some evidence that the virus can basically infect our body through the eyes. So yes, ideally, if you can protect your eyes, that's great. But we also understand that that's incredibly difficult, and having access to a full face coverage mask is also very difficult. So whatever you have at your disposal, if it just covers your nose, I think that's better than no protection at all.
Great. Thank you, everyone. I want to be mindful of time, and I want to make sure we get to Elridge, although we said this is going to be an hour. If it goes an hour 15, that's okay too. But I want to talk about something that we see going on in our communities. There's a lot of fear around potential discrimination, right? When determining who will or will not get treated should they contract COVID-19. A lot of this information or this fear, I think, is being driven by a lot of anecdotal information versus actual factual data. I want to point out that people are working on trying to collect this factual data, including GoTo, directly asking our community through the lung cancer registry some of these questions about impact and what's going on. Others out there are working on it as well, but I want to talk about it because it's coming up a lot and more frequently with patients and caregivers alike in our community. So, Elridge, in light of ongoing media reports suggesting that rationing of care may be inevitable in some state hospitals, can you give a brief overview for us of what's been done to address this concern?
Sure. So in giving an overview, I think it's important to note what's happened. So Congress has passed 3 COVID-19 relief packages, and the president has signed them into law. These series of critical measures aim to provide relief to our states, families, and businesses. And even with the recent CARES package, we know that within the package, it included $100 billion in funds for our hospitals, $150 billion for states and local government to focus on addressing the crisis. Unfortunately, states are still in need of more assistance with regard to relief for healthcare workers, first responders, and hospitals. So in light of the fact that hospitals are in shortage of life-saving medical equipment, beds, and staffing, concerns about discrimination and access to treatment has been a major concern in the disability community, particularly around this time of crisis. I will say traditionally, patients with disabilities have been found to experience bias and discrimination within medical decision-making, and actual examples of disability discrimination were documented in several reports released by the National Council on Disability, which is an independent federal agency. So following numerous complaints by attorneys representing them, this was discriminatory state protocols. And in addition, we saw a bicameral and bipartisan congressional task force with members from various states working together to send a letter to the Department of Health and Human Services, urging the agency to provide guidance to states regarding non-discrimination in the COVID-19 emergency. I will say that most recently, in response, on March 28th, the Office for Civil Rights at the Department of Health and Human Services issued a bulletin entitled Civil Rights, HIPAA, and the Coronavirus Disease 2019, simply to provide guidance to all federally funded entities concerning their obligations under the existing laws and regulations that prohibit discrimination. And it goes to say the basis includes race, color, your national origin, disability, age, sex, including health services as prescribed under the Americans with Disabilities Act, the Rehabilitation Act, the Age Discrimination Act, and certainly the section of the Affordable Care Act. A copy of the guidance that was issued by Health and Human Services certainly can be found on their website, but it's also posted on GoTo's website under our COVID-19 webpage resources. To date, it's my understanding that healthcare providers have been instructed to delay non-essential care during this crisis in order to treat and save the lives of those impacted directly by COVID. And in doing so, it's very important to recognize that hospitals and doctors are taking the precautions to adhere to the federal guidelines to treat everyone to the best of their abilities. But that lays out the overview in terms of what has happened thus far and what brings us to this point.
That's great. I don't know if any of you have any comments. I know, we're just like in other areas, I think we're working hard in this area in order to protect our patient population. And were it so cut and dry as just having these federal guidelines in place, the issue would be, I think, a little bit easier to resolve. But I think in particular in hot spots of this country and other countries where this resource and supply and demand, issue kind of comes into place, sometimes it's not a question of a discriminatory decision, right? It's literally a resource decision. And I think it's really important.
Supply and demand.
Which I think points back to what we were talking about at the beginning of this conversation, around this social distancing and why it's so important to not put that stress and burden on our healthcare system. So thank you for sharing that. Elridge, can you talk a little bit about, is there a role for the lung cancer community to be able to come back and help support some of these efforts by GoTo and others?
Absolutely. And just to piggyback off of what you just last said, I just think the mere fact that our healthcare providers are put in this position of having to ration care is devastating. And so as we think about this, the very first thing that GoTo has done in response is, and I'd like to share this as encouragement, is that we joined a campaign to thank healthcare workers and public servants for serving the American public during this ongoing crisis. And then secondly, as examples in what can be done within the advocacy community, GoTo has joined a disability community in advocating for fair access to treatment to represent all communities. We signed on to what is referred to as a guiding principle for avoiding disability discrimination in treatment rationing. And we shared this document with others to raise awareness and support. And the basis of the principles state that doctors and healthcare teams must refrain from employing assumptions or stereotypes about the worth or the quality of a person's life in making decisions about medical treatment. And so while it cautions them to avoid discriminatory acts, it also says that basically someone should not be, treatment should not be based on an individual's ability to respond to treatment. It is not about the person's diagnosis. It is not about the rationing of what you presume will be the outcome for that individual. The disabilities rights laws cover all health conditions so that a person who has a diagnosis of cancer cannot be the basis, even in part, for denying them any care or making decisions that they deserve a lower priority to receive treatment. On the third front, GoTo is calling upon state governors to enforce our message of anti-discrimination as states are developing their policies concerning how resources should be allocated in response to the ongoing spread of COVID-19. lung cancer advocates can join us in adding pressure to their state governors and the administration to enforce these laws and assure that all are protected under rationing rules at this time. Just to give a few examples of what can be done and what we're doing. For example, individuals can add their voices by reporting any biases that they're experiencing directly. GoTo has posted a Know Your Rights fact sheet, which informs individuals about their civil rights, and it provides instructions on how to file a complaint. Also on our website, you as an individual can emphasize the critical issue of access by contacting your members of Congress, just with the click of your mouse through our Action Center. We provide a form letter in the action alert entitled Advocate for Fair Access to Treatment During COVID Crisis. And you can simply ask your members of Congress to immediately call your state governor and the Secretary of Health and Human Services to ensure that lung cancer patients are treated fairly and are provided with the appropriate treatment. Certainly, working with Congress is not the only way, but we know that working with the federal government is a great way to advocate for so that state plans are improved and represent you and your interests. I would say that GoTo is also in the process of sending another letter to Congress to specifically request that explicit language about pre-existing severe or chronic disease or individuals with immunosuppressed conditions, in addition to disabilities, be spelled out in further guidance on COVID-19 rationing so that our community has the same assurance as all other communities. So there's always opportunities to weigh in, but it always starts with you, the individual, you, the patient, sharing your experiences and letting your representatives know how best they can represent your interests and your needs. And I would just conclude by letting the community know that we're here for them and we're going to continue to advocate on behalf of the lung cancer community and working in collaboration with our partners to protect all human life from discrimination.
And at this point, it's you know, when we've got folks out in our community, you know, asking what they can do to help, I think this is a really important piece of it. And we're all at home. And if you have access to a computer and or even a telephone, I'm assuming maybe you can phone in some of these things as well. Now's time to do it. We've all got time. Everybody in our house has time to do it separately. So thank you, Elridge. Did you want to close out with anything else, or did anyone have any comments on this important issue? Upal?
I just wanted to echo what Elridge said, and thank you so much. And LUNGevity has been doing some very similar efforts, supporting both federal and state level endeavors to make sure that there is no discrimination. But I wanted to take this opportunity to give a shout out to all our healthcare providers. When we've talked to them, and we've talked to oncologists, we've talked to surgeons, we've talked to ER doctors, we've talked to infectious disease specialists, all our HCP community, they have the backs of our patients. None of them want to be taking these difficult decisions, and they are all trying as hard as possible to make sure that we do not have to make these difficult decisions if something goes wrong. So I just want to make sure that we all thank our healthcare provider community, because they are really out there looking out for the lung cancer community, really looking out for us and making sure that they keep us safe and protected in this really crazy time.
Yeah, Upal, I think that's a really valid point. And I know Elridge and I have been talking quite a bit over the last few days, in particular, as when it comes to our healthcare providers and, you know, what sort of, from a government, you know, a fair sort of perspective, what might we be doing to help them, right? So that we can ensure down the road. I mean, right now we're kind of in a it is what it is situation, and we're backpedaling our way through this, right? But how do we set policies in place so that would there be something like this in the future, our healthcare system is prepared for it, so that our professionals aren't having to make these decisions. So I think that's another point that's really important. So thank you.
And I was just going to add that as part of our kind of advocacy group effort this weekend, we had some conversations with LungCan on the issue of triaging, you know, care for lung cancer patients. And I reached out to one of my former contacts at Emory University, who's a leading bioethicist, and he's currently serving as president of the Association for Bioethics Directors. And, this is something that they are well aware of, and they're actually in the midst of collecting these different policies from around the country and, preparing a publication and looking at how, I think going forward, we can have a better process in place. Some of this has been somewhat reactionary, and that I think is maybe the unsettling part of it too, that we would like to think that there had already been a plan in place rather than flying by the seat of our pants, if you will. And so I think the good, you always have to look for the good in these situations, is that we are learning from this. And I think that we will be stronger as a result. We have to kind of get through the current crisis, but a lot of smart people are thinking very hard about this. And to Upal's point, no doctor, no nurse wants to be facing these hard decisions. And so what we can do to help them not have to make those hard decisions is social distancing and staying home and doing all the things that can help them not be in that position. So
Great point.
And I
Thank
think from the patient perspective, we're so used to having to battle to make sure doctors are aware of the latest treatments in lung cancer and that they know targeted therapies help people live longer, that sometimes we just automatically get reactive, that they're not thinking about us. Well, in this case, to echo what Danielle said to start this conversation, this isn't a decision that they're making because they don't think we're worth living, that our lives aren't worth saving. It's a resource decision. And they're faced with two people who have equal right to live, and only one of them is going to get the resource. So I was so pleased to see that the medical ethicists are active and that the disability groups are active. When we're in conversations with the oncologists, they're aware that this is a patient concern and they're thinking about what they can do to educate the critical care providers about the changes in lung cancer survival. There's a lot of people who have our backs.
yeah, I think that's a great irony in this, is that, just at the beginning of the year, we were celebrating, the encouraging news coming out, showing a decline in cancer mortality and the, progress that we were making in lung cancer as a result of immunotherapy and targeted therapies, and how that was, extending, improving, saving lives for patients. And now the irony that we're facing a respiratory virus that is almost mercilessly going after the lungs. It seems like an injustice, right? Because we know that we've made so much progress, and our community is maybe uniquely vulnerable because of just, how this virus happened to emerge, and that it likes the organ that we all care so deeply about. So yeah, it's a challenging time, and my concern is, we don't want to lose that momentum for cancer research, and hopefully, we can do what needs to be done right now to address COVID, but we want to maintain all that progress we've been making. So, that's another piece that I think we'll talk about more in the future. But we want people to continue to advocate for sustained investments in research, not just lung cancer research, but all research, because we need all of it right now.
And individual patients, if you are really concerned about how you might be impacted by this, talk to your doctor. Talk to them about your concerns. Talk to them about your health status and see what they can do to help you.
One final encouraging thought. I was just going to share that recently I listened to the remarks given by Queen Elizabeth, and she said, "We will succeed and the success will belong to all of us." So there certainly always has been a role for each of us to play in our own healthcare, certainly in the governing of our government and policies. And now if we all take on the fight to fight off this virus, we will all succeed together, and the success belongs, the credit goes to all of us.
What a great ending.
That was great, Elridge. Upal, do you have anything before I close out with some final thoughts?
So I think Elridge beautifully summed up what I think we should all be talking about, that this is going to be a collective victory for the community.
I agree. I could not agree more.
And like she said, also Queen Elizabeth, we will meet again. You know, we're all in our homes right now, but the day will come when we will be together again in person.
Absolutely.
And so, you know, don't give up hope. I don't think any of us have given up hope. That has always been there and that remains.
Thanks, Amy. So I just want to close with a couple of things. You know, we started this talking about social distancing and that sort of leading to why it's important, of course, but that's sort of one of the things we didn't touch on was how that can lead to people feeling isolated, right? And isolation can be difficult. So I just want to remind everybody of some of the resources that we have out there available for you to connect with our community, either through our Phone Buddy program, social media, our online health groups through Health Unlocked or Belong. There's telephone support groups out there. Of course, there's the helpline, there's the living room coming to you weekly. And you know, that's just some of the resources that we have. There are other groups out there that have many other resources. So find something that works for you and helps you through this time. I think it's really important. If you guys have any questions about any of those programs that are directly related back to GoTo, please don't hesitate to reach out to us. If you have any questions about this afternoon or evening or morning, wherever you happen to be watching from, living room, please reach out to us through livingroom@gotofoundation.org so we can help direct your questions to the appropriate panelist. I want to close out with just a reminder about where you can find access to some of the things that were talked about during tonight's meeting. So Bonnie and Lori also had put out a blog statement today around this discriminatory issue. That's on our COVID-19 webpage on the website at gotofoundation.org. You can also find on that same very page the civil rights link that she was talking about if you want to dig a little deeper into that. The action alerts that she discussed around how you can get and stay involved. Also the principles of guidance and anti-discrimination that were endorsed by both GoTo and LUNGevity as well as others. You can find access to that there. And then we touched briefly on a document that's sort of a work in progress through LungCan, which is a collaborative document really addressing some of these concerns and you know, being supported by GoTo Foundation and trying to help you to figure out how to best ask your physician for maybe a letter if you feel like you need one should you come down with the virus. So please don't hesitate to reach out more about that as that develops. Huge thank you to our panelists. I can't get the live around the room clap, but I'm sure you're getting virtual claps from wherever people are holed up watching this meeting. I can't thank you all enough. I value each and every one of your opinions in this, as I know our community does as well. Our next living room will be next Tuesday, April 14th, same time, same place, different speakers, TBD. We're working on a couple of different options right now. For our events, I know some of you may or may not know this, but everything has been postponed indefinitely, at least for the near future, but please go back to our website and check out to see what might be going on from a virtual aspect and how you might be able to participate that way. And I think that's all my housekeeping stuff, other than, of course, to thank all of our generous supporters. Without their support, we could not continue to bring this to you. Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Genentech, Lilly, Merck, Novartis, Oncocyte, Takeda, and Foundation Medicine. Thank you for your continued support. And last but most definitely not least, to our patients and caregivers out there who are watching. We do this for you. Please don't be shy about letting us know if there's something in particular you want to hear about, because we will do everything we can to bring it to you. So with that being said, until next Tuesday, thank you all. Enjoy the rest of your days, and we'll talk soon. Thanks everybody.
Danielle.
Thank you.
Bye, everybody.
Thank you. Thanks, Danielle. Bye-bye.
You're welcome. Thank you all.
you.
Bye.
Bye.